who's going to talk to us more about lifestyle and counseling strategies in low resource settings.
Great. Thank you, Dr. Anekwe, for an excellent overview. I'm going to switch gears now and go a little deep on a topic that is the foundation of obesity care. I have no disclosures. I work in the stroke belt where obesity is waging a war on our most vulnerable patients. About a decade ago, we began challenging the status quo of putting band-aids on chronic diseases stemming from obesity. So at our institution, we started addressing this public health crisis by treating obesity first. So in 2019, we launched a decentralized primary care-based weight management program with the goal of increasing access to obesity care for all residents of North Carolina. We provide comprehensive longitudinal obesity care, billing primary care copay rates, providing services in person or via telehealth to adults and children within our communities. You could imagine the demand was so high that in 6 years, we expanded to 17 primary care clinics in over 9 North Carolina counties. We are now a full service line for the entire UNC Health. Moving to our topic, the current guidelines say we need to refer all adults with obesity to intensive multi-component behavioral interventions. But what is the current practice on the ground? Well, the medical nutrition therapy, the intensive behavioral therapy, health coaching, they're not widely used, especially in the underserved communities. There is limited insurance coverages, workforce shortages, clinics lacking capacity, and the high time demand for our patients. So even when they are covered, the number of visits allowed barely scratch the surface. The reality is the underserved communities are being left behind, worsening health disparities. And this is deeply concerning because these are the communities with the highest obesity rate, the highest ultra-processed food consumption, and the least access to GLP-1 drugs. So if lifestyle change is the foundation of obesity care, and many lack access to these counseling services, how in the world do we get our patients from the picture on the left, consuming mostly ultra-processed foods, to a healthier plate option on the right? Do we just prescribe medications and do pharmacotherapy-only approach and just pray and hope that they eat better? Here are some ultra-processed food facts. These are estimates based on NHANES data using NOVA classification, which is a system for categorizing foods based on the level of their processing. In half the adults in the US, 60% of their diet is ultra-processed. For kids and teens, 67% of their diet is ultra-processed. I can tell you that in the stroke belt, these numbers are far worse. There is overwhelming data that shows significant association between high ultra-processed food consumption and adverse health outcomes with increased risk to cardiometabolic diseases and death. This article was very helpful for us in developing the framework on how we deliver lifestyle counseling in our communities with limited resources. The study analyzed almost 160 recordings of PCPs giving weight loss advice to their patients. The dominant approach was a generic message: eat less carbs, move more. It wasn't tailored to patients' existing knowledge or behaviors. It was scientifically unsupported. It's unlikely to result in weight loss if followed. Patients say generic advice is completely useless and unhelpful. The conclusion of the study was this: clinicians need clear guidelines on what to say to patients with obesity about weight loss that is evidence-based, personalized, specific, and effective. So Personalized guidance appears to be the critical factor that drives meaningful behavior change. So how can we do this? 6 years ago, we did a literature search on ultra-processed food screening tools. The closest thing we found was the Food Frequency Questionnaire, which is a validated tool used in nutrition research. But it was completely unusable in clinical settings. There were too many questions, like 100 questions. So we adapted the questionnaire and simplified it, as you can see on the slide. We categorized by drinks, breakfast, lunch, and dinner, snacks, frequency of eating out. Patient filled it out while waiting for us. And we have found that the screening tool does an excellent job of identifying and quantifying ultra-processed foods and sugar-sweetened beverages. We have photos of foods all around the exam rooms, which reminds patients that improves food recollection. So here is our simplified lifestyle counseling approach. First, we do a comprehensive lifestyle inventory. Second, we link enormous consumption of ultra-processed food to chronic diseases and their obesity. We use small steps approach to decreasing their ultra-processed food consumption. For example, when we cut ultra-processed food intake from 80% to 60%, we see real health improvements and significant weight loss. And here's the reality. Ultra-processed foods are everywhere. They're cheap, they're convenient, and it's impossible to cut it out completely. So instead of an all or none approach, what works for our patients is guiding them to ultra-processed foods with less added sugar, less saturated fats, and more protein. We use simple food language, avoiding abstract micro-macronutrient language such as polyunsaturated fats. We use SMART goals, specific, measurable, achievable, relevant, and timely, that is cost-sensitive and convenient and culturally appropriate. All team members are trained in the same approach. Weight management clinicians, dietitians, pharmacists, as well as primary care providers. This approach minimizes missed opportunities to assess and titrate down ultra-processed consumptions. Okay, so I hear this a lot from my primary care colleagues. Dr. Rowe, I don't have time to do this. I'm so busy treating all the chronic diseases. To that, I say, your patient's chronic diseases will literally melt away if you treat obesity first. And this is where we start to provide effective titration of sugar-sweetened beverages. So, the standard nutrition advice is, I just read a lot of clinical notes, limit sugar-sweetened beverage, or we hand out a 5210 guideline, 0 sugared beverages. Here's our approach that has been so effective. Ours is personalized and individualized. We identify and quantify. For example, 2 cups of orange juice, 5 cans of cola, 1 large cup of sweet tea. When I measure all the added sugars, I often find my patients consuming greater than 50 to 100 teaspoons of added sugar per day. We link sugar-sweetened beverage with obesity and chronic diseases. We start setting goals using small steps that's personalized, patient-driven, and clinician-guided. So, for example, decrease 5 cans of cola to 2 cans, swap 2 cups of orange juice to whole fruits, swap 1 cup of sweet tea to unsweet tea with stevia. We have excellent follow-up that has built-in accountability. When goals are met, we celebrate and we titrate down. When there's unmet goals, we continue to work on these goals. Okay, so if we identify a patient consuming large amounts of ultra-processed food, we have found that showing them a Mediterranean diet with salmon and arugula plate rarely changes our patient's behavior in our population. 2 factors patients value the most in food choices is this: cost and convenience. We have seen more behavior change when we offered middle-of-the-road solution, such as healthy frozen meals, meal delivery service, or meal prep options. I tell patients not all frozen meals are created equal, avoiding the carb-heavy ones and choosing lean meats and vegetable options. This is a patient education tool that we develop to guide our patients to healthier processed foods. We guide our patients towards Greek yogurts with less added sugar, low fat, and higher protein. We created one for breakfast cereals, protein bars, frozen meals, and beverages. These tools have been highly effective. Patients tell us every day they now know what to buy when they go to the grocery store. One word about nutrition advice. One size really does not fit all. An approach may work for a certain segment of the population in different parts of this country, but it may not work for many in the underserved communities. I have seen this often. We have patients consuming enormous amounts of ultra-processed food, and when I read the thousands of clinical notes where the counseling language is filled with abstract micro, macro words that our patients can't understand, like monounsaturated fats, hydrogenated oils, etc., and recommending foods that patients would never eat. There seems to be a complete mismatch, okay, of the education level, health literacy level, socioeconomic status, and they're often not personalized. They lack consideration for cost, culture, cooking skills, and convenience. So I tell my colleagues, you can have all the knowledge in the world, but if your patient can't follow it, it is completely useless. So I wish that example was a one-off, but it is not. I see this mismatch frequently in our clinical settings. So in the era of GLP-1 drugs, are lifestyle counseling efforts still relevant? I hear this a lot from my primary care colleagues. My patients are losing weight just fine on the GLP-1 drugs without any counseling. Well, to that, this is what we have observed. Anti-obesity meds allow patients to establish a healthy relationship with food, and it is a golden opportunity to help patients develop new habits while their appetite is suppressed. This is our observation in the stroke belt on patients who have been on semaglutide for 5 to 7 years. Their food environment has not changed, and if no one worked with them on their deeply entrenched lifelong eating patterns, their old habits return. And due to the high cost of GLP-1 drugs, this one study showed that 70 to 80% of the patients stop GLP-1 after 2 years. Okay, and they go back to their old ways. So why should PCPs be involved in lifestyle counseling discussions? Well, they're well positioned to address lifestyle behaviors. Patients view PCPs as a trusted source, and 78% make dietary changes as a result of these conversations. Your time and attention will be worth the effort because nutrition is that important to our patients' health. Okay. So what are some lessons we learned? In the stroke belt, we needed a different approach. Our approach meets patients where they are. We use any accessible anti-obesity medications to treat the underlying physiology of obesity, and we use simplified lifestyle interventions delivered by an army of clinicians. First, we assess the current behaviors. 2, we set personalized goals. 3, we provide the longitudinal care with built-in accountability to titrate down the ultra-processed food at every visit. For the future, we are about to launch a UNC weight management pathway for primary care providers, incorporating the best practices of obesity care directly into the primary care workflow. We are also exploring the use of AI to scale our simplified lifestyle counseling approach. In conclusion, working in the stroke belt has compelled us to think outside the box and develop a different counseling